Thank you again for joining us for today's clinical webinar entitled Spotlight on Potential Interactions Involving Behavioral Health and Substance Use Disorder Medications. My name is Dr. Savannah Clary, and I will be presenting today's webinar. Today's discussion includes highlights from a recent data analysis of potential drug interactions identified by definitive testing. So let's get started. Our objectives for today are to describe the potential clinical and economic impact of drug-drug and drug-food interactions, or DDIs, as we will refer to them throughout the presentation collectively, and associated adverse drug events, or ADEs. List patient characteristics and circumstances that may assist in evaluating the medical necessity of DDI analysis by definitive toxicology testing, and will review reported DDIs within a time frame of Aegis Interact RX testing, with special attention to drugs utilized in the behavioral health and substance use disorder treatment settings, or SUD settings, and discuss drugs and classes of drugs most often involved in DDIs. The impact of DDIs can be extensive, with both clinical and financial ramifications. First and foremost, DDIs can contribute to adverse drug events, or ADEs, which can range in severity from mild discomforts to life-threatening effects. DDIs may be more likely to occur and may cause more of a clinical problem in some individuals. This could depend on the number and type of medications that they take, recent events in their medical care, like care transitions, or just generally the person being more medically complex. DDIs can easily go undiagnosed and undetected, which contributes to the estimated $30.1 billion cost to the collective healthcare system. The risk of an ADE or a DDI increases with polypharmacy, and the number of patients taking 5 or more prescription drugs, which is the definition of polypharmacy, has more than doubled between 1988 and 2018. Also, patients with multiple chronic diseases taking multiple medications and seeing multiple clinicians may be at increased risk of DDIs and related ADEs. There are tools currently available and in use to help clinicians identify and prevent DDIs. Unfortunately, there are limitations to the use and effectiveness of these. First, the potential for human error prevents us from totally relying on a patient's self-report of their home medications. They might leave some out accidentally or choose to omit things that they might view as irrelevant or unimportant, like herbal supplements and things of that nature. Pharmacy-based drug utilization reviews may not be comprehensive if the patient uses multiple pharmacies or again takes OTC or herbal medications that are not known to the pharmacist. Prescription drug monitoring program data is robust, but it is only inclusive of controlled substance data, and automated DDI identification software is only able to analyze the data it contains. Again, omissions can limit the efficacy of this tool. Aegis offers a definitive testing option that identifies the presence of many commonly prescribed medications, as well as over-the-counter supplements and foods. When a sample is submitted for adherence testing, the clinician has the option of selecting Interact RX testing as an add-on test. The Interact RX test is a definitive test completed by LC-MS testing. Positive results from adherence testing and Interact RX testing are assessed for DDIs. Potential interactions are reported on the final laboratory report showing the pair of interacting substances, the interaction severity, and a clinical description of the interaction. Interactions will only be reported for substances that have been detected in the patient sample. Many drug classes are tested in the Interact RX testing tool, and this is not just at a class level. All of the substances listed within each class here are tested when Interact RX testing is ordered by a clinician. Again, positive results from any of these substances are checked against positive results from medication adherence testing, and resulting potential interactions are reported in order of severity, with contraindicated interactions being reported first at the top of the list. Here are some high-level details about the data analysis that was performed. The samples included were those collected between January 1st, 2021 through March 16th, 2023, for which DDI testing was ordered and DDIs were reported. The DDI data was examined for the frequency of interactions by drug class involved. Interacting pairs of substances involving behavioral health and SUD medications have been selected for special focus. The analysis included over 500,000 potential DDIs reported from around 169,000 samples. Of these interactions, 2,136 unique pairs of interacting substances were identified. This chart shows the proportion of interacting drugs among the top 30 interacting drugs detected and reported during the analysis period. Many commonly prescribed medications were found in the top 30, most frequently involved DDIs. Of note, buprenorphine was the most frequently involved drug, with over 105,000 potential DDIs involving buprenorphine reported during the analysis period. Amphetamine was also frequently involved in potential DDIs with over 33,000 instances. Citalopram or escitalopram, quetiapine, bupropion, duloxetine, fluoxetine, and methadone were also represented in the top 30. These potential DDIs include both pharmacokinetic and pharmacodynamic interactions. Looking at the data by drug class, antidepressants and antipsychotics were involved in a significant portion of the potential interactions reported, with over 238,000 reported DDIs involving drugs from these classes. Opioids and benzodiazepines also contributed to a significant number of interactions. The substances with abuse potential that you see there at the far right includes things like methamphetamine and alcohol. Illicit drugs are not included in the DDI analysis. While the methamphetamine that is represented in this substances with abuse potential category may be illicit, there are other potential sources of methamphetamine that are not illicit, so that is why it is included. Again, referencing the opioid and benzodiazepine involved interactions, this is a good reminder that similar pharmacodynamic interaction potential exists with use of designer opioids and designer benzodiazepines as well. While novel psychoactive substances are not included in the DDI analysis, their potential pharmacodynamic impact on the patient, especially in combination with prescriptions or other illicit substances, should be considered when evaluating the results of toxicology testing. Couple of key results from this analysis. DDIs can certainly impact treatment success. With over 1 in 5 reported DDIs being a potential interaction with buprenorphine, this demonstrates that there are frequent instances of additional medication use that may alter the pharmacodynamic effects or the efficacy of buprenorphine. Patients may experience adverse effects or reduced effects of the medication depending on the specific interaction. Almost half of the reported interactions involved an antidepressant or antipsychotic medication. Identifying interactions that are contributing to adverse effects and potentially creating adherence barriers can improve the patient's experience with their medications and help promote adherence. Some limitations and exclusions from the data analysis. The analysis was not inclusive of all samples received during the time frame, as DDI testing is only performed as ordered by a clinician. Medication adherence testing is only performed according to clinician order as well, so there could be additional substances present in the specimens that could contribute to additional DDIs that were not reported in the results. Thus, the data presented here could be an underrepresentation of the true frequency of DDIs occurring. Substances that were identified in DDI testing but were not found to contribute to DDIs are not reflected in the interaction data presented, but their presence in the sample could help inform prescribing decisions that help to avoid DDIs. To recap our main points of emphasis for today, DDIs do have the potential to lead to ADEs of a wide range of severity potential, ranging from mild to life-threatening. DDIs can affect medication efficacy and treatment success. Analysis of potential DDIs in urine or oral fluid definitive testing can help provide additional clarity and transparency regarding an individual's substance use. And when thinking about patients who may be candidates for DDI testing, consider those displaying intolerance to prescribed therapy, reduced response, or requiring dose escalation for effective treatment. Patients with risk of an incomplete medication profile due to the complexity of their past medical history, and patients at risk of morbidity from drug interactions. All of these may be good candidates for consideration for DDI testing. If you would like to read additional details regarding this drug interaction data analysis, please check out this month's clinical update article on our website at aegislabs.com. Go to the resources tab that you see there, slide down to the clinical update button and click on that. You'll find the article dated June 19th, and it is a more in-depth discussion of the content that has been presented today. Our clinical team is available if you have questions about today's presentation or any other clinical or result interpretation questions. Please reach out to us on the phone or on the email on your screen. We look forward to talking with you. Thanks for listening today. A recording of today's webinar will be available on our website soon. I hope you all have a great day. Bye-bye.